Me, felicitate Dr. Irfan Ismail Ayub.
Thank you, ma'am, for the invitation to be part of this day where we observe World No Tobacco Day 2025. I am Dr. Irfan. I am from the Department of Respiratory Medicine. And I will be talking for the next 15 minutes, not very clinically, but in terms of the context of what or why we are victims of the tobacco industry and how we can overcome the addiction. As an acknowledgement, we are always who we are because of our teachers and of course our parents and families and friends. And most importantly, our patients teach us everything, and we should always be thankful to them. About me, I'm a professor in the Department of Respiratory Medicine. I feel that the easiest way to connect with the audience is to ask the audience to introduce themselves, but I feel that this is a very big audience, so I'll introduce myself. I'm basically a person from Chennai. I've studied here in Santom, finished my medicine in Coimbatore, did my internal medicine in Chandru. I did my pulmonary fellowship at AIIMS New Delhi, and I've been here for 10 years in Sri Ramachandra Medical College and Research Institute. I'm an exennial, that makes it somewhere between 77 and 83, almost double your age. I'll take it as the lower end of probably 83. I have my parts in my talk divided into three parts. I'll be talking about, primarily first, I'll be talking about nicotine addiction. Why do we go into nicotine addiction? How does it start? And then I'll be talking about what we can do to come out of addiction. And then we'll talk about the support systems. See, when you start to understand addiction, there are almost around, let's say, 300,000 chemicals out there in the market, but only 100 of them are addictive. The most common addictions are nicotine, alcohol, marijuana, opioids, cocaine, and you have an entire list. Of course, meth, famous by the famous TV series. And then you have the behavioral addictions. A lot of addictions like excessive shopping, eating, exercise, and so on. The predominant discussion here is, of course, nicotine addiction. But we will say that the same thing applies for all addictions. That addictions will require some form of counseling, some form of behavioral therapy, and some form of therapeutic therapy as well. So why do we start smoking as we're talking about nicotine addiction? I think this is one of the classical pictures of superstar with all that intense smoke coming out. I think the most common reason is because of style, or what we call as peer pressure. We see our colleagues, our friends smoke, and we tend to smoke, or the Tamil form of it, get it. Some people smoke for pleasure, hope, acceptance, because when you smoke, you tend to find that you find acceptance within a circle of friends or community. Some people smoke to avoid pain, depression, physical pain, abuse. Some smoke for fear, rejection, peer pressure, as I said. Media receptiveness. We see people smoke on TV, on television. We feel that's the thing to do and we tend to do it. And then we have parental influence as well. Sometimes we have parents who tend to smoke in front of us and that kicks the habit in us. But these are all actually reasons for why we should smoke. But we are clinicians, we are scientists, we are doctors. I think we should have a scientific explanation for why we should, or why this habit kicks in and why does it stay for a long time. And this requires me to enter into the domains of the Department of Physiology and why we have nicotine addiction. So you have the reward center in our brain, the nucleus accumbens, and that's where anything that we do that makes us feel good, that part of the reward center gets activated. And that makes us feel good, so good that we want to do it again and again. So you have nicotinic receptors, namely known as the alpha 4 beta 2 subtype receptors, which are there in the ventral tegmental area. When someone starts smoking, the intense exposure of nicotine in the cigarette smoke gets inhaled, then enters into the blood system or into your blood, activates the nicotinic receptors which are there in the ventral tegmental area, and that releases dopamine. Dopamine then reaches the nucleus accumbens, and that makes you feel good. So you get a happy smile. Now, this seems to be very simple, but it's not as simple as it looks. This is actually my diagrammatic representation of how the reward center gets stimulated by anything we do that makes us want to do it again and again. Sometimes some people do donations. They give a lot of money, philanthropy, and you find that they keep repeating it. It's because maybe their nucleus accumbens get stimulated again and again, and they feel happy doing it. Why are some substances more addictive than others? This is actually a slide from a paper published in, I think 2008 or 2009, where they did PET scans. PET scans are scans where they look at metabolic activity in your brain, and they ask these patients to inhale cocaine. And then they've asked a set of patients to take cocaine IV. And they find that once the IV cocaine enters into the system, you can see a lot of uptake. Is there a pointer in this?
Center.
So you can see the uptake in the cortex as a result of the IV cocaine, and the levels of cocaine reach so high that corresponds to the high that the patient receives. And subsequently, the cocaine levels start dipping down, and you can see that within 30 minutes, it's back to normal. There's no cocaine in the brain, and that's why they give an intense high, and that high then disappears within half an hour. This is when the drug is being given IV, intravenous, because it reaches your brain much more quickly, unlike nicotine. Nicotine takes hours for it to start affecting the brain. But this is an example, or you can say that this can be replicated, and it can be extrapolated to any other addictive material that can produce the same effect. So substances become more addictive if they can reach your brain faster, especially those which are taken IV, and then those drugs which are inhaled take a longer time, and that's why they're not so addictive as IV drugs. So as I was saying, addiction is much more complex. So when you say addiction, you're trying to say that the reward center has to be stimulated, which means that someone has to smoke a cigarette, and after smoking the cigarette, the nicotine reaches your brain and makes the dopamine level go up, and your reward center becomes happy. But addiction is even before that. Even before he starts smoking the cigarette, when he sees the packet of cigarettes, he starts to have the tendency or the craving for the cigarette, and that's addiction. That means even before he starts smoking the nicotine. That means how does the dopamine get released even before the drug reaches your system? And that's why it's much more complex. So you can see here that this was the initial slide that I had shown, the cigarette smoke and the nicotine reaching the receptors. Well, now the cigarette is not there, the smoke is not there, but the person just sees the cigarette, and even that will actually make him feel good. The reason is because that's an example of a natural reinforcer versus a neutral stimulus. The reinforcer here is the cigarette smoke or the nicotine that makes someone get addicted, but now the neutral stimulus is just seeing a pack of cigarettes or just seeing an advertisement for a pack of cigarettes. That's enough to make the person have his reward center get activated because of the released dopamine. And that's how addiction works. Addiction works even before the drug reaches your system. So as a clinician, now that we have given a scientific basis for addiction, how do we approach nicotine addiction? So how should we react when this person comes up to us and says that he's a smoker, he or she is a smoker, or a patient comes up to us and says that they have got a smoking history? Do we show scorn, or do we condescend on these patients? Do we show pity, sympathy, empathy, or compassion? These looks like the colors from the inside of the movies. But these are certain emotions that we need to control when we speak to our patients. We are clinicians, we are actually having a choice on how we react when a person talks to us. So when a patient says that he's a smoker, we could look down at him and say, you brought this upon yourself, you did this habit, that's why you have this problem. Or we can show pity, yeah, right, you're a smoker, there's not much we can do about it. We can show sympathy, we can say, okay, I feel for you, but that's it. We can show empathy, maybe sit down with the patient, trying to understand why the patient is smoking. Or compassion, we can actually get down to the basics and treat the patient. What's the difference between all of this? Anyone? The most important here is, as clinicians, as doctors, we should show compassion more than sympathy or empathy. The reason is because we have a choice. We can choose to be what we want to be at that point of time when the patient comes to us. If a patient comes with, say, lung cancer, and he's been smoking for 30 years, you could say, it's all because of you, you started smoking and that's why you brought upon this. Or we could just forget that aspect and show compassion, treat the patient, because we know that there's a scientific basis for addiction. It's not their fault that they got addicted, it's upon us to get them out of addiction. So we are the chosen ones to choose how we can react, and we should try to show compassion. That scene is from The Dark Knight, 2008 DC Comics, where Batman chooses to be the bad person at the end of the movie. Here we can choose to be what we want so that the patient starts to feel better. So once you've identified a person who's smoking, the WHO has a set of guidelines. How do you approach a patient with a history of smoking? First of all, you ask the patient, are you a smoker? If he says yes, he or she says yes, then you advise. You need to stop smoking. Smoking is harmful. Smoking has a lot of bad effects. And then after you have finished your advice, you assess. Do you wish to stop smoking? Do you want to stop smoking? And if the person says yes, you assist. All right, then I'll tell you how to go about to stop smoking. I'll send you to a program, a behavioral therapy, maybe some medications, and try to arrange the next clinical visit for this patient. It's a very straightforward approach by WHO, recommended all over the world, followed by all institutions. But when you go through this passage, you do know that when the patient starts to stop smoking, there will be withdrawal symptoms. We know that dopamine is a very addictive addictive hormone in your dopaminergic neurons in your reward center. And all this time, this person has been smoking cigarettes and has been releasing so much of dopamine. Suddenly you ask him to stop smoking, the dopamine levels are going to go down. And that means that his reward center is no longer going to get stimulated. And you're going to see that once they stop smoking, their nicotine levels will drop within 1 or 2 hours, and they will start craving for cigarettes. So then how do you tide over this? You need to identify the symptoms. These patients will come to you saying that once I stopped smoking, I started having headaches, coughing, cravings, increased weight gain or appetite, mood changes, changes in the heart rate, difficulty in concentrating, influenza-like symptoms. Some people then have constipation. And the good news is all of these symptoms can be crossed over a period of less than a month. It means that you need to just sit through it. Any one of you who have patients or who know people who are trying to go through this phase, you just need to encourage them. You need to tell them that it's just a matter of 2 to 3 weeks, 4 weeks at the most, and all of the symptoms disappear. Your brain gets adapted to the new dopaminergic system. You have replacement therapies. People who are so much addicted to nicotine, they have this craving so much. You have nicotine replacement therapies in the market. You have nicotine gums, you have nicotine patches. You can prescribe this for patients where they can apply this, or they can take this, they can chew the gums. That gives them some amount of nicotine without the smoke, and therefore gives you a replacement level of dopamine and satisfies the reward center. And gradually, these patients wean off of the symptoms. You also have other medications, what we call as antidepressants, bupropion and varenicline, probably out of context in this age. Then came vaping. People said, okay, you have now an electronic cigarette. Electronic cigarette is a way of trying to stop smoking. Someone who's smoking 30 cigarettes per day suddenly says, okay, I need to stop smoking, but I can't, because once I stop it, I get withdrawal symptoms, so I take the vaping cigarette. The vaping cigarette has a very minimal amount of nicotine and has been shown to reduce the dependence or the withdrawal symptoms that comes with nicotine dependence. However, what happens is this becomes a new addiction. Someone then starts to become addicted to this. And what is very important in this e-cigarettes is this propylene glycol. Now, many e-cigarettes actually exchange the propylene glycol and they put ethylene glycol. And that's where all the problem starts. Your e-cigarettes then become contaminated. They start producing all kinds of syndromes, infections, influenza-like illnesses, organizing pneumonia, lung fibrosis, whatever. It's something like out of the fire into the frying pan. Trying to come out of cigarette smoking, but they end up with a new problem. And vaping then became an epidemic of sorts in the United States, and I think in 2019 they banned vaping. And in almost, I think, half the states of the United States. And in India, we have banned it, I think, from almost 1.5 years ago. But having said that, it's still available out in the market, in the black market. But you must understand that vaping doesn't solve the problem. It just makes you dependent on another form of nicotine, another form of delivery device, and kicks you into a different system completely with a different problem. But the other problem with this vaping is that people who have never smoked tend to think that if I want to have this habit just for the style, for the get, or for the, say, acceptance, they go directly into e-cigarette thinking that e-cigarette is going to give the same craving. But actually what happens is now they become addicted to e-cigarettes, and they were not even at all addicted to nicotine in the first place. So this becomes a new venue for addiction. And now the government of India has banned it from the country. What happens if you have a patient who chooses not to say that I want to stop smoking? You have asked, you have assessed, and then you say, okay, I will assist you in stopping smoking. He says, no, I don't want to stop smoking. Then you need to find out the reasons. And this is again another program by the WHO, the 5 R's in a smoker who's just stubborn, who says, I don't want to stop smoking. You need to see the relevance. You need to ask him, what is it that keeps you smoking? What is the relevance? Why do you want to smoke? Are you smoking because you want to have some form of, say, fear that you want to overcome, some kind of anxiety you want to overcome, So see the relevance of he's smoking. What is the reason? Explain the risks. Tell him or her that these are the risks of smoking. You're going to get cancer, you're going to get COPD, and all forms of diseases like oral cancer. Tell them the rewards. Once you stop smoking, what happens? Good things happen. And what are the roadblocks? Try to address. Why is he not smoking? Is it because he's got peer pressure? Is it got parental influence? And keep repeating this again and again. So how do you address this patient? As I was telling you before, you need to explain the relevance, the risks, and the rewards. So let's look at some of the things that you can explain to the patient. This is a very famous curve known as the Fletcher-Pitot curve, 1977. It's there in almost every physiology book, every respiratory medicine textbook. Nobody will write a textbook without having this curve. These two scientists, or physiologists for that matter, actually came up with this curve, where you can see that this is the normal FEV1, force expiratory volume 1 in your spirometry. If you keep it as 100% of maximum, it goes on slowly dips, and by the time the person reaches an age of 80, it's somewhere around 75. And this is for someone who does not smoke. And for someone who smokes regularly, you can see the dip, the lung function just drops. And at any point of time, if the person stops smoking, it changes. You get a different trajectory. Something like the trajectory that you saw in the Avengers in Endgame. So you can see a different trajectory completely. And then you see that these patients will now have a different FEV1 once they stop smoking at any point of their time in the natural course. So even if they stop smoking at the age of 50, you get a better lung function. If you stop smoking even at 65, you get a better lung function compared to someone who continues to smoke. Which means that it has no late time to stop smoking. Once you decide to stop smoking, you have to stop. You can explain the magnitude of the problem to your patients. You can see here all kinds of heart diseases, ischemic heart disease, CVA, respiratory tract infections, COPD, HIV, diarrhea, tuberculosis, and malignancies. And in all of them, what is the contribution of smoking? You can see that smoking contributes this much of this group, this much of this group, this much of this group. So in fact, smoking tops almost at least 10 to 20% is a risk factor for all these diseases. And then you can explain, once you've stopped smoking, what are the good things that happen? The rewards of stopping smoking. This is again from the WHO guidelines. You can see here that once they stop smoking, within 20 minutes, your vitals become better. Within 12 hours, the carbon monoxide levels become better. Somewhere at 1 year, the heart risk becomes that of half of a smoker. And 5 years, 10 years, 15 years, the benefit keeps continuing. The risks of stroke, lung cancer, coronary heart disease, everything starts reducing. Which means that once smoking is stopped, you get benefits from the moment it's stopped. Next slide, please. And it moves on as far as altogether years altogether, 30, 40, and 50 years age group. You can see the life expectancy increases. Next. You can always explain to them how much money they can save if they stop smoking. You could ask them to put a chart. How much money do they spend on tobacco per day? How much money is spent per month, per year, 10 years, and then you can ask them to calculate that, and then they could probably put an estimate and say they could have probably gone around the world, for that matter, for the amount of money that they spent. Next please. Or you could probably just put it blindly, bluntly, saying that for all the money that you spend on all your cigarettes, they will build a big hotel and then invite you and then ask you to spend more money there dining. Next. See, tobacco cessation is not just your effort. As a clinician, you can do all this 5 days, 5 hours, you can get the patient in, you can give nicotine replacement therapy, but you need some kind of governmental support. You need a system in place, a kind of a collective effort by a team. Next please. So you have government initiatives. You have the National Tobacco Control Program. You have a hotline for it. There's a hotline that you can call toll free, and when you call this number, they will give you information about tobacco cessation and what are the therapies available. And then the government has made it clear that 100 yards within any school, any college, any university, there should not be any tobacco sale. I'm not pretty sure whether this is still valid. And then you have the health advisories that come with every pack, every cigarette, every movie, every OTT platform, whatever you call it. They tell smoking causes cancer, smoking kills. And these are some of the government initiatives. We have initiative at our institution at Sri Ramachandra. We have the tobacco cessation clinic. It's in chest OPD, ground floor, OP number 4. We have a number and an extension number. Please share this information with any of your family members, any of your friends, colleagues, anyone that you know that you think, rather than showing sympathy or empathy, move into the compassion age group. Try to see whether you can make a difference in that life of a person. This is open from 8 to 2 every day, Monday to Saturday. They can always walk in. There's always a personal counseling, and we do offer therapies for addiction. So summarizing, not to go too in deep into the topic. So what is the lesson that we've learned here? Smoking is stylish, but you can still have style without a cigarette. Next. That was just a joke. Next slide, please. The real lessons learned here are nicotine addiction is a science. Please do not be judgmental. Do not show an attitude where you start showing pity, or you start showing scorn, or start looking down at them, condescend upon them, thinking that it's all your fault, it's your problem. No. There's no room for judgment. We are clinicians. We know that there is a scientific basis for this. There is a reward center that's being rewarded continuously by this addiction. And it's upon us to intervene, to show some compassion, to show some offer in therapy. For every patient, get the 5 days done. And when you start the nicotine, when you stop the nicotine addiction, when you say stop smoking, there will be withdrawal symptoms. Some withdrawal symptoms are very light. They'll just last for 2 to 3 weeks. You'll just tide over it. You don't need any medicines. But some patients require therapies. You have nicotine replacement therapies like gums, you have plasters and patch and so on. But please understand, vaping is not a nicotine replacement therapy. That doesn't work. It only causes another problem. And for a smoker who's reluctant, explain the 5 R's. See the relevance, explain the risks, show how the lung function drops, show all the data available about cancer, and how their money is being spent by the big tobacco industry building hotels and selling biscuits.